Welcome to DM Neurology MEDC. This is the 24th episode of 5 Neurophilia Quick Revision series. Let's see the part 1 of Ataxia and PRION diseases video.
Inherited ataxia part gets importance in case of entrance exams. You just need to read through PRION diseases. This 11th module, I'll just just give a brief intro regarding it's to generate neurophilia among students, basically graduates and postgraduates, and to motivate and guide you for a fun learning, and to kindle interest in basically reading textbooks of neurology. I would say neurology, rather it's Harrison basically, and to get you prepared for the changing patterns in the neurology entrance exam, and also to get inputs from great neurologists, which we'll get in the due course of time shortly, and to reduce the communication gap between the practicing and the studying, that is aspiring neurologist. So lots of books you can read, but don't miss reading this book, that is Harrison, which is the basics. And advanced learning, you can go with the Bradley, new edition is yet to come. So with that, let's go to the topic. I'll just start with one word, that we are all ataxic. That is, the word meaning of ataxia means it is lack of order. So let's make everything in order with this question to start with. So this is regarding a 60-year-old female who had a slowly progressive gait abnormality, that is walking difficulty with tremor of hands. Otherwise healthy, not on any medications, no speech difficulties or no visual abnormalities. She didn't have any family history. And on examination, her higher mental status was normal. She had no cognitive decline. She didn't have any abnormalities in the eye movements, that is no nystagmus or any speech slurring of speech, dysarthria. Her power was normal. Her deep tendon reflexes were sluggish. At this time, I will say that her sensory examination was actually a bit abnormal. So with this history, and she also had a broad-based gait. So with this history, what do you think the patient is having? This is the patient who previously could walk, slowly progressive gait problem, previously could walk with 1% support because of ataxia, then needed 2% support. Now she cannot even go to bathroom, and she needs everything besides her bed. And if you see, I am just asking her to raise the hands simultaneously in front of her. She has crisscrossing of her hands. She's unable to put it straight. So this is another view of this patient. So what am I doing to this patient? So I am asking her to keep the both arms straight, and you can see how the hands are going. So it's kind of a movement disorder. For me as a beginner, if I am a beginner, I would just think that it's a movement disorder. So what do you think? And what am I doing right now to the patient with my left hand? Just asking you. I know you all of you know the answer. I hope all are able to see the video. Most of them have answered it as correctly as sensory ataxia. Some are confused because I am taking a class on cerebellar ataxia, whether it's cerebellar ataxia. I don't know whether the people who have answered Brenn's ataxia know what is Brenn's ataxia. I'll come to the point. Whether it's Brenn's ataxia, sensory ataxia, cerebellar ataxia, or vestibular ataxia. And before going to the answer, I'll ask you one more question. What is being elicited in the video given above? So I asked you specifically what I did with my left hand to the patient. So what was I doing? So I just closed her eyes while asking to put her hand straight, right? So when I closed her eyes, her hands went helter-skelter, went here and there. So that shows. So Romberg's is always, most of them have answered it as Romberg's. I'll tell that Romberg's is actually a sign which is elicited in a standing position. You almost know. And patient loses balance once the visual cues are lost. So it is a sign of proprioceptive loss. And so it's not Romberg's, it is actually pseudoathetosis, what we are seeing. Pseudoathetosis is being elicited. Ataxia just means lack of order. And this lack of orderliness could occur due to anything as shown in the figure. It could be a cerebellar problem, a sensory problem, a vestibular problem, and a frontal lobe ataxia. It's otherwise called an apraxia, or difficulty to do an learned activity in a proper way, in an orderly fashion. And For that, we have a different term that is called Brunt's ataxia. It is actually not an ataxia, it is called an apraxia. And mixed things are there, especially in elderly, and also psychogenic. And also, you know that in elderly, the patients may have a cautious type of gait. So every ataxia, you have to keep in mind that it needn't be cerebellar. So ataxia just means it is lack of orderliness. The same patient, I just wanted to ask you, what did you see here? You see her hands going something here and there. So her all fingers are going in different planes. So this is actually what is otherwise called piano playing movements in case of pseudoathetosis, because her all fingers are not able to keep the proprioceptive impulses right, and it's going as its likeness. And that is typically seen in case of pseudoathetosis in case of sensory ataxia. So it is not a case of cerebellar ataxia and is a sensory ataxia. Now see this case. This patient also presented recently with walking difficulty, wide-based gait, and ataxia. So what do you think this patient is having? There is no confusion. I didn't give any history. I just told that the patient had a wide-based gait, and I tell if those are in doubt, I'll show you the video again. What is happening to her? She's unable to know where to keep the feet, ahead or no. And you see, is the video choppy or are you not able to make out? She's actually getting stuck there. It's kind of freezing. So this is actually a frontal gait disorder which could be easily missed for a cerebellar ataxia. So this is actually a frontal gait apraxia. So this is a frontal higher level gait disorder, or it's called Brunt's ataxia. Brunt's ataxia. So cerebellar gait, as you know, is classically what we are studying from the MBBS. It is wide based and it has all the features of a cerebellar problem. So as you know, cerebellum is the one which moderates all the activities. So we have the periphery which gives inputs to the cerebrum, that is your brain. And this periphery tells you how to move, where to move and all. But it is moderated especially by, or controlled especially, or fine-tuned by the cerebellum. So when cerebellum is actually damaged, then we get dyssynergia, that is irregular variable movement, dysmetria, that is erratic food placement, and disequilibrium. And you know all the cerebellar signs: ataxia, dysarthria, dysmetria, eye movement abnormalities, including nystagmus. And in case of frontal gait disorders, it would be wide-based gait with apraxia, basically apraxia. And you know, because of the frontal problem, you will be having all the frontal release signs. You know what are the frontal release signs? Basically, palmomental reflex, increased jaw jerk, snout reflex, glabellar tap, etc. will be present, and there will be cognitive impairment and bilateral pyramidal signs if it is there, with bladder dysfunction. And sensory ataxia. So our case, which I had shown in the beginning, first case was actually sensory ataxia. So this patient also will be having a wide-based gait, but patient will be having a high stepping or a slapping gait, because patient would not know where to place her feet, and it would be of a varying stride length, because each time she or she places the feet, she won't be knowing the exact position in respect to the position. And also with the loss of visual cues, or when she closes the eyes, or in the night, she loses balance more. There is more imbalance, especially in the evenings, and she tries to compensate it by looking over to her feet. So that is why the sensory ataxia people tries to look towards the feet and walk. And there will be, as you know, other signs like pseudoathetosis, as we have seen, Lermit sign in case of dorsal column involvement, and Roebuck sign, wash basin sign, and cotton wool sensation, etc., with associated peripheral nerve involvement. So how many neurons do you think is there in the cerebrum of the human brain? How many neurons do you think are there in the total brain as such? And how many neurons do you think is there in the cerebellum? Total number of neurons in the human brain is actually 85 billion. And it has got a vast number of connections. 10 raised to that much connections are there. And only 15 billion are there in the cerebrum or the telencephalon. And 70 billion, you can remember that out of the 85 billion, 70 billion are present in the cerebellum. So you can think of the importance of cerebellum in the brain or the controlling the human activity. So cerebellum has that much of importance, and that controls that has about 70 billion neurons, and out of the 85 billion total neurons in the human brain. So where do you think the cerebellum arises from? Is it the metencephalon? Is it the myelencephalon? Or is it the mesencephalon? Or is it the prosencephalon? Metencephalon. So as you know, the brain, the final embryology part we have discussed in a previous lesson. We cannot spend time on that. So prosen, meson, and rhomben. The rhomben further divides into meten and myelencephalon, and the metencephalon divides or forms further into pons and the cerebellum. So cerebellum is formed from the metencephalon. Okay, and myelencephalon forms the medulla. So cerebellum actually is an organ of three. So everything in the cerebellum can be divided basically into three parts for our convenience. So we learned about the rule of 4 by Peter Gates for easy identification of the posterior circulation of strokes. So similar way, actually cerebellum can be understood very easily with this kind of mnemonics, like rule of or organ of three. It's kind of law of three, which we study in case of cerebellum. So cerebellum, if we divide into three, phylogenetically it can be divided into vestibulocerebellum, spinocerebellum, and cerebrocerebellum. So just remember one thing, that apart from the normal cerebellum, what stands out is actually archicerebellum or vestibulocerebellum. That is the oldest part of the cerebellum, which contains the floccular-nodular lobe. Basically, and then comes the paleo and the spino, which forms the vermis and the paravermis, and the neo or the cerebrocerebellum, which forms the lateral hemispheres, which helps in the limb movements. That is the fine movements of the limb. And this paleo and the spinocerebellum has the input from the spine, and the archicerebellum from the vestibule. So the name itself explains everything and the phylogenetic division of the cerebellum. And the arteries basically is superior cerebellar artery, anterior, inferior, and the pica. So you know, pica is derived from the vertebral artery, and you should just remember that the basilar forms the SCA, that is superior cerebellar, and the ICA. And superior, the word itself says that it supplies the topmost part of the cerebellum, that is the superior part, and the ICA forms the lateral part, and the posterior inferior cerebellar, as you know, supplies the lateral and the inferior part. So that is why we get the lateral medullary syndrome along with the lateral inferior cerebellar involvement in case of pica tertiary affection. So basically remember three arteries, that is SCA, ICA, and pica. And this is the actually the infarct area. And the lobes are actually divided basically on the fissures. Primary fissure is there, posterolateral fissure is there, and one horizontal fissure is there, which I'll show you in the posterior section. And so anterior, posterior, and the flocculonodular. These are the basic MBBS things, just to make you refresh things. And peduncles, as you know, it is connected to midbrain, pons, and medulla. So superior, middle, and inferior cerebellar peduncle. So this part you should give some importance, because inferior cerebellar peduncle is otherwise called restiform body. So this part I'll tell you a bit deeply. So as you know, we were telling regarding cerebellum. So cerebellum, if you want to take a cup of tea from a table, the input regarding our input regarding the taking of cup of a tea from the table actually goes, and our hand moves towards the table. So this movement of the hand, that the proprioceptive impulse goes back to the brain, and before going back to the brain, actually it goes to the cerebellum here through this pathway. That is, proprioceptive information goes through the inferior cerebellar peduncle or the restiform body to this pathway, and one part goes to the brain as such, and it needs to be refined. That is why it goes to the brain and then comes back. So that is, the input from the proprioceptive pathway goes through the inferior cerebellar peduncle and goes to the brain, and from the cortex it comes back to the brain, whether it needs to be refined and all. So cerebrum, from the cerebrum it goes to actually the pons. Cerebellar is actually through the cerebropontocerebellar pathway. That is, from pons it is actually middle cerebellar pathway, MCP. So afferent is through MCP, afferent is through ICP. So from cerebrum it goes to the MCP. So here now the cerebellum modulates the movement and or refines the movement and tells that makes sure that the movement is we are taking the cup at the correct position and we are not overshooting it. So if a damage is occurring, then we may overshoot or hit the cup, and we may or not be able to take the cup of tea in front of us. So we have the superior cerebellar peduncle, middle cerebellar peduncle, and the inferior cerebellar peduncle. Middle cerebellar peduncle, superior cerebellar peduncle goes to the midbrain, to the thalamus and the red nucleus. Red nucleus, as you know, is in the midbrain, and MCP to the pons, and ICP to the medulla. So this was what I was telling, three fissures: primary, horizontal, and the posterolateral fissures. So basically it controls three things: tone, coordination, and posture. So that was regarding the basics of cerebellum. So basics you must have studied. It also controls the coordination. So any neurological disease, first whether you localize, then you have, for diagnosing we need to have a temporal association. We have to, so in this case we see whether the disease is occurring in the cerebellum, and see whether it is an acute, subacute, or a chronic disease. So in the case of ataxia, we see whether it is a unilateral or a focal ataxia or a symmetrical ataxia, and see whether it is acute, subacute, or chronic. Subacute is like it's like minutes to hours, and subacute would be days to weeks, and chronic would be weeks to months. There's no clear cut like 6 weeks or something. That kind of cutoff is not there. So with that basic brushing up of our basic MBBS and MD knowledge, we'll just try to solve this question. All of the following are symmetric progressive ataxias. Actually, this is taken from our Harrison textbook. So try to answer. Those who have read Harrison would be able to easily answer this question. Ataxias we can divide first into symmetrical and asymmetric, or focal. So focal and symmetric. Then we divide it based on the temporal association, whether it is acute, subacute, or chronic. This helps to reduce our differential diagnosis while dealing a patient with ataxia. So we don't want to go for a wild goose chase in case of patients coming with ataxia. Yes, we have mixed answers here. So most of them have answered it correctly because it is just there in the table. So as you know, tertiary syphilis stapes dorsalis, we have a symmetric progressive ataxia. Anti-gliadin antibody also is the similar thing. But multifocal leukoencephalopathy, you may get mistaken that that the patient has bilateral brain lesions, but the symptoms most likely are unilateral or more focal to begin with. And gasoline-induced ataxia are also kind of a symmetric progressive ataxia. So if you see this, this is the table from which multiple MCQs could be asked in your exams. So this is the Harrison table. So basically, symmetric progressive ataxias, if you see, divided as acute, subacute, and chronic. And never forget any ataxia case, even your clinical practice, always think of this: hypothyroidism, all the treatable causes always, and have a thorough history of intoxication in every patient coming with ataxias. So, and any patient with ataxia, look for phenytoin toxicity, whether the patient is on any anti-epileptic or anti-cardiac medications like amiodarone and anti-epileptic like phenytoin. So this is the symmetric progressive ones, and the focal ipsilateral ones. What we were talking about was actually this one. Uh, PMLE, as you know, could be multifocal leukoencephalopathy due to AIDS-related one, or due to as you know, in case of multiple sclerosis, post-treatment natalizumab, you can get encephalopathy, leukoencephalopathy. Neoplasms also, it could be focal to begin with, later getting generalized. And as you know, vascular, it's actually by rule, it should be focal, ipsilateral to begin with, and maybe if rarely only get bilateral lesions. And chronic, it could be stable one. So I had just divided the approach into this thing as I told you here. So acute symmetrical for your ease could be toxin, a cerebellitis, or a post-infectious syndrome. Acute one, a toxin intoxication, acutely could. And subacute one could be drugs, toxin again, alcohol and nutrition, and Lyme's disease. And chronic symmetrical one could be inherited one, as we have in our, the inherited ataxias is divided into autosomal dominant, autosomal recessive, X-linked, and mitochondrial. And paraneoplastic, due to the various cancer, we have multiple antibodies, you have to keep in mind. And hypothyroidism is the most treatable and reversible cause of chronic symmetrical ataxia. If untreated, the patient will lifelong suffer because of this. So always look for this. And drugs and anti-gliadin antibody, and as you know, tertiary syphilis, which is rare nowadays. So these are the ones. And regarding the focal ones, vascular, infection, demyelination, as in case of MS. Subacute unilateral one, neoplastic, demyelination, and infection again, based on the type of infection. And chronic unilateral ones, that is gliosis, that is old stroke, etc., patient presenting with old stroke. And congenital ones, as in case of hypoplasia of cerebellum, or a Dandy-Walker syndrome, etc., or congenital diseases, Joubert syndrome, etc. Can Joubert's is usually bilateral. Others can cause this thing, Dandy-Walker, etc. So this was the one of PMLE, leukoencephalopathy. So it can have a bilateral MRI involvement, but presentation could be unilateral. So that was regarding our temporal association of cerebellar diseases. So for the ease of that studying the table, I had divided the table for you. You can just, after seeing this slides, you can go back and read the table. Otherwise, single look at the table, you may not feel like studying the table or knowing what to read in the table. So now you will be able to go through the table. Which of the cerebellar ataxia which of the cancer with anti-TR antibody causes this paraneoplastic cerebellar ataxia? Breast cancer, ovarian cancer, it is anti-YO antibody. Small cell lung cancer, it is voltage-gated calcium channel. Hodgkin's, it's anti-TR. And you know, myoclonus obsoclonus, that is the rapid eye movement, irregular rapid eye movement, will be having anti-RA antibody. Also in lung cancer and neuroblastoma. And also GAD antibodies will have progressive attack. Anti-GAD antibodies will have progressive attacks. So now we come to the most important part in case of ataxic syndromes, especially being asked in the case of our MCQs in the entrance exams. So which among the following is an autosomal recessive ataxia? This is a plain simple question introducing you to the basic inherited ataxias. So try to answer this question. Simple question as for you. Ataxia telangiectasia, which is actually autosomal recessive. So what about this spinocerebellar ataxia? As we know, spinocerebellar ataxias are autosomal dominant. There is DRPLA, which is otherwise called Hoare syndrome, which is autosomal dominant again. And episodic ataxias are about 1 to 7 are autosomal dominant. And autosomal recessive ones, as we know, Friedreich's ataxia, ataxia with oculomotor apraxia, that is apraxia of the eye, ocular movement, ataxia telangiectasia, and the ataxia with vitamin E deficiency and other diseases, which REF-SEMS, CTD, the cerebrotendinous xanthomatosis, etc., are autosomal recessives. And that is regarding autosomal dominant and recessive ataxias. N number of ataxias are there, but most important ones only I have just discussed. So just know that SCA, DRPLA, and episodic ataxias are autosomal dominant. This would mostly be there in your MCQs, basically. But other rare things could occur, like hypomyelinating leukoencephalopathy, etc., could come. But usual MCQ should be having these as their options. So next question: which of the following repeats suggest an X-linked inherited ataxias? So as you know, these ataxias could be due to repeats, polyglutamine repeats, etc., etc. And you know, SCA is due to which of the repeat? Spinocerebellar ataxia could be due to multiple repeats, but most SCAs are due to which one of the following repeats? I think first you try to answer this question. Maybe a relatively tough question for you, but try to answer this question. I'm putting these questions because this could come in your institute exams or maybe even Neet exam as a tough question or a decider question. Just emphasizing the fact that while reading the SCA part in your Harrison as well as Bradley, just emphasize these parts also, that is the repeats, etc. Because of this repeats, there is a chance for anticipation, as we see in case of Huntington's disease, in case of spinocerebellar ataxias also. Yes, somebody have put Kennedy. It's okay. It's not Kennedy actually. Yes, it's Fragile X syndrome or a Fragile X tremor ataxia syndromes. Fragile X usually occurs in young people. Fragile X tremor ataxia syndromes could occur in elderly or old people. And it is due to the CGG repeats. And can anyone say regarding what are the other repeats which I have shown here? Because all this has got significance. These all could come as MCQs for you. And these are some common questions. First one is actually a common repeat seen in CAG. Is a common spinocerebellar ataxia repeat. And GAA is actually the Friedreich's ataxia repeat. And ATTCT is actually one of the SCA10 repeat actually. It's a pentanucleotide repeat. SCA10, remember 10 is pentanucleotide. So these kind of questions you have to presume that it could come, especially going to the next level of studying, rather than plain inherited ataxias coming like which of the following is just autosomal dominant, autosomal recessive, X-linked, spastic ataxia, etc., etc. These kind of questions should also come. And what about this Fragile X syndrome? So Fragile X syndrome, more to know about it, actually there will be a MCP hyperintensity in case of Fragile X syndrome, or FX tax, that is Fragile X tremor ataxia syndrome. That will be the MRI findings. MCP, what I mean by MCP is what we were talking regarding previously regarding the basic brainstem cerebellum, that is middle cerebellar peduncle hyperintensity in case of Fragile X. So this is the difference between Fragile X and FX tax, that is Fragile X tremor ataxia syndromes. So the thing is, adulthood presentation will be there in FX-TAS, and number of repeats usually will be less, and it will be a progressive disease with more of ataxia, tremors, and Parkinsonism features in case of FX-TAS. The patient would be having an elongated face, broad forehead, large prominent hair, prominent jaw, crowding, macroorchidism. There will be mitral valve prolapse, hypotonia, joint laxity. Pes planus will be there, and the scoliosis will be there. So why I put this picture is for your memory. So I had put the picture of Michael Phelps. It's not that he has Fragile X, just for his face actually looks like one having FX-TAX. It's not right to say he's having FX-TAX. Let's ask what disease did Michael Phelps had? actually in his childhood. It is actually ADHD only, and he was rumored to have some collagen vascular disease like Marfan's, but it's not sure whether he had or not.